Good evening, everyone. Tonight we have Dr. David Smith with us. He is an MIT-trained engineer who did his medical training at the University of Chicago. He has been a practicing physician for over 30 years now. Dr. Smith is an orthopedic surgeon with Bone and Joint Physicians. They have multiple locations with offices in Oaklawn, Orland Park, Flossmoor, and Calumet City. As we go through the presentation, if you think of any questions, type them into the webinar panel, and we'll answer them once this section of the webinar is complete. First, we're going to start with hip. We'll take your questions about that, and then we'll dive into the knee shortly thereafter.
Thanks, everyone, for tuning in. I'm going to start with just some general things about the hip to kind of get you oriented and talk about some common diagnoses and treatments and approaches to it, and we'd like to leave some time for questions. So if we're missing out on something, let us know, and we'll try and answer it for you. So the first little slide we see up here is a picture of me pointing to a skeleton we have in the office. What I'm pointing to is what would be the groin part of a human being, and that's where the ball and socket is of what we call the hip. Sometimes I know folks come in and they'll refer to the buttock area or low back, so there is some overlap, but the actual hip joint itself is right in the groin. This is something that when I first went into practice, I had read in the paper. They were talking to patients and people as to what they didn't like about doctors, and I often say it was a long list. But when they did ask patients what it was they wanted to know, and basically it came down to these three questions. When you go to a doctor, you want to know what's wrong. Then second, you want to know what you can do about it. And then third, you want some sense of how it's going to turn out. So I try and answer those questions every time I see a patient to give them a perspective. So how do we go about answering the first question? I often use the example of Sherlock Holmes. It requires detective work, and there's a variety of tools we use in medicine. So in other words, a person comes in, says their hip's hurting them, and we have to investigate, gather information just like Sherlock, and come up with an answer. Really important is history. A lot of times in all the fancy tests, we sometimes lose sight of that. And I do know that a lot of patients get online and look things up, and I think that's great. But I just ask them when they're talking to me, instead of using all the fancy medical terms, let's just talk like we're neighbors and explain to me where it hurts, what makes it worse, what makes it better, when it started, how it started. And sometimes that will give me a better picture than someone coming in and telling me they think they have a torn labrum or they think they have arthritis. They may very well, but let's talk about it in common terms. Physical examination is an important part of our gathering of information. Sometimes things will be positive on an X-ray or positive even on a MRI. It doesn't necessarily mean it's causing the problem, and through exam and by pushing and prodding and moving, we'll get a sense whether that image correlates with what we see on exam. Those are important things. X-ray, I like to get them all weight-bearing. So often patients come in and they bring outside films, and they weren't weight-bearing films, and that's important. This X-ray just happens to show a fracture. This is an extreme example of what a person would have. You certainly wouldn't come in the office with that, but X-ray is one of the basic tests we're always going to get. There are some other tests that you don't think about it commonly used on the hip, but ultrasound has been a great thing in the past, I'd say 7 to 8 years I've been using it. And what does it do? It sends a sound wave down into the hip region. It doesn't hurt, and we look at the echoes. What we're seeing here, it looks like a ball and there's kind of a stem. That's actually the hip socket. This dark area we see here is fluid. So that's someone, you've heard the expression water on the knee, that's somebody who's got water on the hip, and that's an important clue in solving our mystery. And then we get into some of the more sophisticated, expensive tests, but important tests, the MRI. As you can see, different than an X-ray, we see not only just the bone, but we see the fluid. It shows us this white signal here. We can see a structure called the labrum, sits up here. We can look at the muscles around the hip. We can look in this area, it's called the trochanter, this knob of bone. And when we're going through some of the diagnoses, we'll talk about trochanteric bursitis, and that bursa is a little pad that sits here and can get inflamed, real common problem. The other is these powerful abductor muscles that hold your body up as you walk. Can often get overused as you get into your 50s and 60s, and you might have some little tears occurring in that area that need mending, and we talk about how that can be done. And then finally, when we're talking about imaging and you get into arthroscopy, when arthroscopy really became popular, I was still in training, and often in those days was used as purely a diagnostic test. Now we can look into a joint and confirm diagnosis, but we can also do some of the surgery. And we'll go over some of the anatomical features that might come out by doing an arthroscopy. This is a surgical procedure where we're actually looking into the joint, this little cannula here, and the light coming out goes to a camera, goes to a lens, and we can observe the hip joint. So, like any great detective, you need some suspects, and oftentimes there's the usual suspects that we deal with in medicine. And I've listed some of them here. Before I go in the room to talk to a patient, I see they've come in for what they've termed a hip problem, I often keep in mind that maybe this is something coming from the back, because there is a close connection between the two. You could have a disc problem, you could have some arthritic problems in your back. They would present themselves as buttock pain or pain along the side of your leg or pain going into the groin. So I often will get an x-ray of the back as well as the hip. Bursitis is probably one of the more common problems I see. Patients will come in and they'll point to the side of their hip region, pretty much where your pocket would be on a pair of slacks. And they'll say, I can't lay on that side. If I sit in a chair and my hip rubs up against it, it hurts there. And oftentimes we'll make the diagnosis of bursitis. And a bursa is a little pad that nature makes around bony prominences. And like I was showing you on the MRI, there's a knob of bone there called the trochanter, and trochanteric bursitis, very common, easily solved problem. I remember a lady I saw some years ago, she came in and she was almost crying. She was just, so sad that she was going to have a hip replacement. And I examined her, and really she didn't need a hip replacement. She just needed a shot of cortisone for her bursitis, and she got better, and there was a happy ending there. So sometimes you think it's something terrible, and you just go ahead and get the diagnosis, and it's not as bad as you thought it was going to be. Muscle strains. When I was talking about those powerful muscles, the abductor muscles called the gluteus medius and minimus, again, patients in our 50s, 60s, and beyond can, from repetitive activity, muscles that are requiring 3 and 4 times body weight strength to hold us up over thousands and millions of cycles of walking as we get into our 60s can get some fatigue tears, and that can cause pain, which we can deal with sometimes by adding a cane or having somebody use a walker for about 6 weeks, put that area at rest and let it heal. Then we get into a group I call internal derangements. That means somewhere inside the hip joint itself, inside that ball and socket joint, there's a structure that sits on the outer side of the socket called the labrum, and that can tear. Now, as we get into our 60s, a lot of people have labral tears, and probably that isn't even adding to the problem, but sometimes earlier in life we see athletes, 20s, 30s, 40s, that have torn the labrum, and that's something we can deal with arthroscopically, but the MRI helps us make that diagnosis. Loose bodies. One of the major categories we're going to be talking about is arthritis. Arthritis is literally a wear and tear type thing where your cartilage starts to wear down. And some of those fragments of cartilage and even bone can come off and get ground up inside the ball and socket joint, and they have these loose bodies. And the symptoms they'll produce is you'll be feeling fine and you walk or turn and twist a certain way, and you get this stabbing pain that hits you right in the hip region, and that's possibly a loose body that's jamming in the joint, and then it'll move and get out of position and it'll be all right. Ligament tears. Particularly during the wintertime, I see a lot of people slip on the ice, they fall, they get an x-ray, they go to the emergency room, they tell them they don't have a fracture, but they keep having pain, and they're glad they don't have a fracture, but they wonder what's going on. And the ligaments that hold the ball and socket joint together, particularly one right in the center of the socket called the ligament of teres, can rupture. This is something that I've, through the years, treated arthroscopically in some cases, not every case, but sometimes that's helpful. I mentioned a few other things. Avascular necrosis. This is something we prefer not to see, but it does occur, and it's something I don't know if anyone fully understands. What it is, that for some reason a section of the bone in the ball part, it's a ball and socket joint, will lose its blood supply. And when it does, you lose the cells that live there that maintain that piece of property. Once they die, the wear and tear of everyday life starts to cause that area to fracture and break down, and it causes pain. And the head, which is normally a ball or a sphere, becomes flattened, and the hip becomes very painful. It can, in some cases, be associated with a little too much drinking, and I've seen it also associated with people that have been on massive doses of cortisone. We're not talking about your occasional cortisone shot for bursitis, but we're talking about someone who's had a kidney transplant or a liver transplant, and unfortunately that can happen. That often leads to a hip replacement in a relatively short period of time because of the amount of pain. And then the most common category, arthritis. And we'll be going over that in a little more detail. So, internal derangement, labral tears, loose bodies, ligament tears, these things can be addressed through arthroscopy. And when I showed you that, this is what we see when we're looking in the lens. This is inside the hip. You can see the femoral head here shaped like a ball. You can see the socket here. This red material is synovium, what lines the joint. It's called synovitis. And that can produce a lot of the fluid. When we talk about water on the joint, these are the cells that are producing that water. This is a thermal device that actually can shrink down tissue, and we can remove some of that synovium. Also, that material called the labrum, you can see here on this picture, and you can see where I'm putting a suture in it to sew it back where it's been torn. And here, where it's frayed and you really can't sew this portion, we're just trimming that off like you'd take a pair of clippers and trim off a nail. So this is the arthroscopic view. You see the ball, you see the socket, you see the labrum. That ligamentum teres I was talking about is deeper down in the joint, and we can often clean that out. These are the loose bodies I was mentioning. They get rounded off many times. They move around. We used to call them joint mice because you had to chase them around to get them out of the joint. So this is just a picture of what the hip looks like with the capsule. The capsule, every major joint, the shoulder, the hip, the knee, the ankle, has a capsule. It's sort of like the clothing that sits around it. And it's made of a series of 3 ligaments. This is the iliofemoral ligament, the pubofemoral, and the back is the ischiofemoral. And that's what we go through to get inside the joint. But that slip on the ice could result in a tear of this capsule. And sometimes that can be treated very successfully with a period of rest and some physical therapy. A lot of times the tearing results in scarring, gets tight, and all you need to do is get it stretched out in therapy. So again, we come back to a little bit of arthroscopy. You can see in here the ligamentum teres where it was torn, and this is a bit of labrum we're cleaning out. So what if the answer to the question, what is wrong, and then the answer is arthritis? What can you do about it? What is arthritis? The most common type of arthritis I see on a daily basis is the bread and butter osteoarthritis, also known as degenerative joint disease. Now, just to make a little separation here, some patients have inflammatory arthritis, can be associated with psoriasis, psoriatic arthritis. It can be rheumatoid arthritis. And rheumatoid arthritis is an overgrowth of the lining of the joint called the synovium. And it can destroy the joint, the cartilage, and the capsule. Many years ago, when I came out of training, there were terrible cases of deformity and joint destruction from that. In my 30 years in orthopedics, I've seen the most advances in the treatment of rheumatoid arthritis. The medicines and injections that have come available have really made people's lives better, and for many of them prevented them going on to joint replacement. However, osteoarthritis is a different creature. We think of it as a wear and tear process. We think of it as joint inflammation associated with loss of cartilage. And what is cartilage? Cartilage is the tread on our joints that caps the bone. In the hip, it's a ball and socket joint, and both the socket and the ball are coated with cartilage, a very slippery, smooth material when you're young, and it's a healthy joint. As time goes on, that can break down. And that may be the primary problem in osteoarthritis. That cartilage, for some reason, the cells in it start to die and it starts to lose the ability to repair minor little scuffs and breaks in the cartilage, and that leads to degenerative joint disease or osteoarthritis. It's a complex area in some ways and simple in others, but it's that loss of that tread on the tires that causes it. And here's a healthy hip and there's an arthritic hip. And what we see is a smooth, glistening surface like we saw in some of those arthroscopy pictures. And here you see the pitted area with the bone spurs and the roughness. And that's basically, I've seen many hips today that look just like that. Patients coming in with osteoarthritis. So the cartilage came loose. These little pits you see is where those loose bodies come from. And that's what produces the pain. So we said the second question after we decided what's wrong, is it arthritis, is it a loose body, is it a torn labrum? Let's say it's arthritis. And what treatments do you have for arthritis? And we're talking in general about osteoarthritis, the common type. Well, I try and give myself little memory devices, and years ago I decided that there were 5 categories of treatment that I provided to patients. And I always, every time I saw a patient, made a diagnosis, I wanted to make sure that I considered every reasonable treatment so they would be aware of how they could deal with their problem. 1 is medications, 2nd is injections, 3rd is bracing, 4th is physical therapy, and then surgery. So let's kind of run through some of those. Anti-inflammatories, what are called NSAIDs, non-steroidal anti-inflammatory drugs. Here's a box of Celebrex, and that's one of the newer ones. Some people think it's a little controversial. I won't go into all the details of that. I take it myself occasionally, so I think it's a good medication. Anti-inflammatories, all of them have some side effects. Millions of people take them. Unfortunately, 7,000 to 8,000 people a year die from them. And everything in life has risk. You know, I think it's 40,000, 50,000 people a year die from automobile accidents, but we drive. And millions of people take anti-inflammatories. But the message is not to scare you, but to inform you that if you have diabetes, if you have a history of ulcers, if you have some intolerance to taking these things, you need to check with your family doctor or your orthopedic surgeon or your rheumatologist and maybe get some blood tests to make sure you're not beating your kidneys up or your liver and you're not getting any problems with your GI tract, your gastrointestinal, your stomach, your intestines. So, and there's a variety of medications other than non-steroidals. One of the classes is what's called chondroitin sulfate glucosamine, and it's sort of a mouthful, but this is a medication that's available to you at the drugstore without prescription. And there's been a lot of studies on it. We'll talk about that a little more in the knee area, but basically when I look at things, it's sort of like what the FDA does. I think the Food and Drug Administration in our country does a good job of taking care of us and looking after the safety of something and the effectiveness. And I think both need to be considered. When something seems to be very safe and it helps some people, I think it's worth considering. And I think chondroitin sulfate, glucosamine, those combinations can be helpful. There's a formulation of it, there's a brand of it, Cosamine DS, that matches the dosage that was done in some major studies, and that's what I often recommend to patients, to give it a try. They're fairly large pills. I tried taking them myself occasionally, and I found that the internist told me that if you take it with applesauce, it's a lot easier to swallow, and that's a good trick. With water, it's a bit. So, non-steroidal anti-inflammatories, chondroitin sulfate glucosamine, and there's probably 80, 100 different ones. Motrin, Advil, you get at the drugstore. Aleve, which is naproxen without a prescription. Then you get into Relafin and Indocin, and it goes on and on. But they're worth a trial for some people with arthritis of the hip. Injections. This is something we do in the office. We use ultrasound or we use fluoroscopy. And I know when I first mention it to patients, they sometimes think, oh my goodness, that's going to be painful. But we use a very small needle. We use water-soluble cortisone. We freeze the area. And through the years, one of the more common things I'll hear people say after we've given them the injection is they'll be, that's it, you're finished? I go, yes. So I don't think it's anything you have to dread. And a lot of my patients that have arthritis who are not getting better with the pills can be helped by the shots. And I found that I've had numerous patients I've kept going for many years. Some of them were in the trades. They just couldn't take time to get a hip replacement. And we keep them going and keep them comfortable with the injections. Bracing. There really isn't a good elastic brace that I've ever found. Basically, it comes down to canes and walkers. And I know that doesn't make people too happy to hear that, but again, I've encouraged patients, try it for about 6 weeks and see if you can quiet the thing down. Sometime, if you can get control of the inflammation, put the area at rest, the body can heal itself. It's not going to eliminate the arthritis, but it may give you a little more time. Physical therapy. Almost every joint in the body that I treat, I think, can benefit from physical therapy, particularly the hip. I saw a person today that I had seen about 3 weeks ago, severe arthritis, a lot of restriction in motion, weakness of the muscles around the hip, sent him to therapy, saw him today, 3 weeks later, significantly improved. So stretching out that capsule, mobilizing those muscles, getting the strength built up again is a major factor in improving a joint. And even if that person goes on and down the road of life and has a hip replacement, they're going to have a smoother recovery and an easier course of things if they've maintained that joint motion and maintained those muscles. So therapy can help you in either way. Surgery. You know, we've talked, there are several approaches. I just want, for the sake of completeness, we'll run through these. Arthroscopy. What role arthroscopy plays in the treatment of arthritis is somewhat controversial. And basically, for milder forms, there is the possibility they will help some patients. This is an area I'm very interested in. Certainly the severe advanced cases are not going to respond, but I think in the early treatment, again, for a patient who feels that they want to temporize things, to put off doing the hip replacement, but they want to get more comfortable, hip arthroscopy can help. Osteotomy, what's that mean? Well, basically that is cutting the bone or breaking the bone and changing the alignment. Back in the late 70s, early 80s, more of this was done, but as the total hip replacements have become more reliable, have lasted longer, I haven't seen one done for many years. So basically it comes down to hip replacement. And I think if you did a survey of orthopedic surgeons and said, what is the most successful operation in all of orthopedics, it definitely, I believe, should be hip replacement. Started in the late 60s by a man named John Charnley in England, and it revolutionized the treatment of hip arthritis. The history of orthopedics and hip problems, there's a learning center we have here, in Chicago. It's called Rosemont Center. I go out there and they have a little display or museum of devices that were used through the early years to try and help people with hip arthritis, and it's a sad collection until you get to Sir John Charnley, who revolutionized the treatment of severe arthritis with the hip replacement. So this is how Dr. Charnley did it in those years, and when I learned early on, we actually took off the trochanter, this knob of bone here. We said people get trochanteric bursitis, and in those days we kept people in the hospital, probably 7 to 10 days and sometimes 2 weeks. Then they'd go home. Nowadays we use this anterior approach, and the average stay is 2 days, and I've had a few patients who have left the day after. And there are some surgeons sort of pushing the envelope a little bit and sending people home the same day. So I'm not yet ready to make that jump, but I think it's certainly possible in some cases. I believe the monitoring for a day or so is well worth the potential benefit. So, and this just shows you there's a socket we put in, metal rim, there's a plastic liner, there's a ball and a stem that goes down here. So different schools of thought developed over the years. Charnley was an English fella, and he tended to take the trochanter off. Then there was a man, we talk about the French, but really it was a German named Euler. The French kind of came along with the anterior hip approaches, but they're all, you see these different things. I don't want to bore you too much with the approaches. Trans-trochanteric was Charnley taking up that piece of bone. I don't know anyone that really does that nowadays for primary hips. In other words, a hip done the first time. Posterior approach, about 80% of the ones done in this country are done through the posterior approach. There's a few who do the Watson-Jones, which is coming in from the side. Good approach. The downside of this one, let's talk about each one. Well, the downside of this one was you cut that piece of bone off and you rewired it, and that didn't always heal, and it created some problems by itself. So there you had an approach to do an operation to cure problems, and you produced another problem. So that, I don't know anyone that really does that nowadays. Posterior approach, very good. Most orthopedic surgeons are most familiar with that. They learned to do it, and it can work quite well. The downside of that is there's a higher frequency of dislocation, the hip popping out of place. It's a relatively low thing, a low frequency, but it's 20 times as high, according to the Medicare statistics, in the posterior approach as it is the anterior approach. And everyone's got their favorite, and they'll debate the merits. But now Watson-Jones, that was coming in from the side and removing some of those strong muscles I was talking about that hold you up, and then sewing them back on. Unfortunately, maybe 10–15% of people would develop a limp that just wouldn't go away. They would have weakness. It was a good approach. You could get the device in. The dislocation rate was low, but the problem was the weakness that it produced. So here you can kind of see the wires that were put in the old Charlies. I actually remember doing a hip like this years ago. I was at the VA, and these earlier implants weren't as strong as they are nowadays. I haven't seen it since. It fractured, and we had to drill down and get this out. So those have changed and improved. The lateral approach we were talking about, where you're taking off a piece of bone. But in the posterior approach, it had its advantages. That you preserve those muscles along the side, but the risk of posterior dislocation and a longer recovery time led some of us to think about the advantages of doing it a little different way. We didn't like the weakness with the Watson-Jones. So first call this the French preference. What do we mean there? There were a group of, I think it was a grandfather, a father, and then a son through the years named Judet, who were famous surgeons in France. I believe it may have been in Paris. Around the 1940s, one of them developed a table to use for approaching the hip through what was known as the Smith-Peterson. Unfortunately, no relation to me, but the Smith-Pete approach was used, but this table really made it easier to be able to do major joint surgery through that direction, and people tended to do better. You didn't disrupt the muscles, you didn't have a lot of the problems you had with the other approaches. So that was Robert Judet in 1947. And when I came out of training in the late 1970s, early 80s, I worked with a doctor who did the anterior approach without using that table. And in those days, we were using cemented devices, and it was a little easier to put them in from the front. And I really learned a lot from him in terms of how good of an approach it was, and how well patients did, and how low a dislocation rate they had. And his patients did remarkably well. After training on that trans-trochanteric approach and seeing his approach, I knew that was a lot better. But about that time, cementless devices were coming along, and it really was not possible on a conventional operating table to put in these cementless devices, which got rid of some of the problems we had with cement technique. So things went along, and they went back to the posterior approach after that. So about 1996, Dr. Mata, who I visited some years ago, came up with a modified table and the technique to do these with modern cementless hip replacements. Anterior means front of the body. So we kind of go in this interval in the front. And actually the ball and socket joint is more toward the front of the body, anterior, than it is posterior toward the back. There is this Smith-Pete approach goes between the muscles. You don't have to cut any muscles to get in there. And it's actually between two major nerve groups. So it's like if you had two cable systems running through your town. If you're going to dig any trenches, you'd want to dig it between the two cables, not crossing over any of them, because that would cause a problem. and it preserves what we call the hip deltoid. That's those powerful muscles I keep talking about, called the abductor muscles, gluteus medius and minimus. When we did that Watson-Jones approach, that weakened those. So I had a lot of advantages. I've been doing it now for probably 8-9 years, and done well over 1,000. I've been very pleased. And what's really important, I feel the patients have been improved. Anytime I've ever done an anterior approach on a patient who had a previously done posterior approach, I can't think of anyone who preferred the posterior over the anterior. So this is, if you were to point to your groin where the ball and socket joint, you point about here. These are the muscles we go in between, the tensor fascia muscle and the sartorius. You divide those, and you can slip right down to the capsule of the hip. It's a very quick approach. The table allows us to position the leg so we can get to the thigh bone or femur to put in the stem, that portion of the total hip. I think it does help with limits of soft tissue trauma. The muscles are less stressed, and I found it really advantageous for just about any size patient. This lady kind of shows what we're doing here. Imagine we were operating on this hip, positions the leg down, and it exposes the hip region so we can get in there and get it done. This is what we're actually putting in. There's a cup, a metal shell that goes into the what's called the acetabulum. There's a plastic liner that's put in there. These are the trials we call broaches that we actually make the path to put in the final implants. This is the system I use. It's called Carai, and it is actually, this is a French system. It's been around for many years. Had an excellent ingrowth record, so that's probably the most common implant we use. So smaller incision. I feel you get better alignment. When we do the surgery, the person's lying on their back. So the pelvis has sort of a complex geometry, and if you, the other approaches are done, particularly the posterior, with the person laying on their side, and the person tends to lean forward and backward, and it's hard to get good x-rays. So for positioning the cup, for checking the leg length, I think it's better. My impression is patients have less pain from this approach than they did from the posterior. I feel it's certainly a quicker recovery from what I've seen. And I've had everything from patients leaving the day after surgery to the average of being about 2 days, which is, compared to the old days, is very good. So what a hip looks like once it's installed, you can see over here the natural ball and socket joint, and here there's the shell, which we see here. There's the plastic liner, and there's the stem sitting inside the pelvis. Obviously the muscles are not there. Okay. Well, I think it brings us back to hip arthroscopy. So we've kind of did a quick tour through through hip land, and we're going to leave some time for questions. Let me just sum up by saying this: that basically what we tried to show you today, there's a lot of things that can cause hip pain. Some of them are fairly simple to treat. Shot of cortisone, a little bit of physical therapy, and they get better. There are more significant things like arthritis, and after a period of time, some of them do go on to a point where the only thing to do is a hip replacement. And I think the good news there is it is an excellent operation, no matter how it's done, anterior, posterior, side. Patients are very pleased. It's been a very successful procedure. So if there's any particular questions anyone has, feel free to let us try and answer them for you. And in a few minutes here, then we'll be going on to the knee for those of you interested in that area.
All right, it doesn't look like we have any questions regards to hip. So if you're ready to move forward.
Yep. Are we on? All right, folks, hang on to your hat. Here we go. Knee. Knee's a common problem every day I'm in the office. I see lots and lots of knees. And I kind of like this expression: total knee replacement is not the total answer. So often I see people that have been told they have arthritis, and I feel some of them have the impression that it's, you know, when it gets bad enough, you get a knee replacement. Until then, you're kind of on your own. And I think it's important to realize there's a lot of things you can do. I've had many patients I've taken care of for 10, 15 years with arthritis, and we tried to find ways to keep them comfortable and put off the surgery when we can. So here we go. Knee problems. The common things people come in for: one, it hurts. It doesn't feel, it feels unstable, almost like a friend you can't depend on. It feels like it's going to collapse or fold up. And then stiffness, sort of the other end of being too loose is being too stiff. If you can't bend your knee very far, it's hard to get in and out of a chair, hard to get in and out of the toilet. It's hard to get in and out of your car. And it's often painful trying to walk on any terrain that's not real smooth. So this is something I start all my talks with, and I say every time I see a patient, I want to try sometime during the time I've been treating that person, try and answer these three questions. What's wrong? What's causing the pain, stiffness, or instability? Then the next question, what can they do about it? What are your options? And very seldom is there just one thing you can do. Almost always there's several categories to consider. And then finally, how can it turn out? Let's say if later on here I'll be talking about the 5 approaches I take. And I think for each one I try and answer a patient and say, well, you know, if we do the gel injections, I think in your particular case I'd estimate the probability that it's going to get better is about 6 out of 10. That means 4 out of 10 that you'll go through it and it won't improve you. But it gives the person at least some reference of where I think this thing can go. So the first question, again, we want to be like Sherlock Holmes, detective work. We need to gather information like Sherlock did, and we do that through history, physical exam, x-rays, ultrasound, MRI. Just kind of briefly go through that. This is something I said on my talk on the hips, and that is basically I know nowadays a lot of times I have a question about anything, whether it's around the house or the car. I go to the Google and try and put some things in and get some answers. I know a lot of patients do that. I think it's excellent. But when you come to talk to the doctor, I just think it's better if you talk to him like your neighbor. And instead of using fancy terms and throwing in your diagnosis, what you think it is, and I certainly respect that, but I want to know in common terms, what makes it hurt? Is it going up and down stairs? Is it when you sit too long? Is it when you stand for too long? Does it limit your walking? So just common sorts of things. And so, you want someone to sit and talk to you a little bit and listen. And they used to tell us in medical school, if we'll be quiet and listen to our patients, a lot of times they'll give us the diagnosis. Physical exam, really important. We have a lot of advanced test imaging nowadays, and they certainly are helpful. But you really need to correlate it with what you see on physical exam. X-ray is the fundamental thing we start with. This little thing shows weight bearing. And the reason I get weight bearing is you can take an X-ray that looks like this, in which it's bone on bone when it's weight bearing. And if you took one non-weight bearing, it might have a pretty good joint space. It'd look much better than here. And I've often seen that when patients come in, they bring films with them, aren't weight bearing, and they'll say, well, why do I need more films? And the reason is we want to get it with you standing. Ultrasound. You tend to think of pregnant ladies and babies, and it's been a wonderful test, and it's amazing the technology. I used to be an electrical engineer, and I marvel at the image quality, how it's improved over the years. We can use it on the knee. Some of my patients have implanted devices that don't allow them to have an MRI. And so the ultrasound can help. What we're looking at here, it's a little hard unless you're in the business, but that's the edge of the bone, and this is the edge of the bone. And in between is the structure we'll be talking about called the meniscus. And here we see this dark area here. That's a little cyst, fluid collection, and it communicates through this little line here, which is a tear in the meniscus. So that's a torn meniscus. The patient came in with a little bit of swelling and tenderness, and the MRI gave us the answer. Now, if you're a sports fan like I am and sit around watching a lot of sports, you'll hear about some poor athlete when they're dragging them off the field saying, well, tomorrow we'll know more when we get an MRI. Here's what the MRI shows. When you compare that to an X-ray, you see the bone, you see the cartilage. See, this is the tread on the tires. This is the good stuff, sort of the icing on the cake that makes it efficient and comfortable for a joint to move. If you don't have good cartilage, you don't have a good knee. Now, there was an old term, torn cartilage. It got a little confusing through the years. They're referring to this structure, the meniscus, this little black triangle here. It's a pad that sits in your knee, and it can tear. So we're not talking about tearing this cartilage. We're talking about a torn meniscus. And there's cartilage on this part of the knee called the tibia. We can also see the muscles. Sometimes there's cysts that form back here. As we go through, we can look at the tendons, the quadriceps tendon up here, part of the patella. We can look at the cartilage underneath the patella. We can look at the tendon here. So understanding anatomy is really key to understanding knee problems. Anyone's interested in historical reading, John Hunter was a famous surgeon considered the father of modern surgery. He became a great surgeon by studying anatomy. And he and his brother started an anatomy school where they dissected bodies. And in those days, in France, you could dissect the deceased, but in England, you couldn't. I guess that was the lack of an enlightenment from them. But in any case, he persisted, and he learned a great deal about disease and treatment through studying the anatomy. So we'll do a little bit of that right now. When you look at a leg, if we take the skin away, we see muscles that give shape to our upper leg. This is called the quadriceps. It comes down and connects to the patella, which gives a little mechanical advantage to the muscle pull. When you straighten your leg out, it increases the strength. That's why kicking is such a forceful activity. When you see someone kick a ball, how far they can throw it with kicking with their leg versus throwing it with their arm. Then the meniscus is this pad we were talking about. There's two of them. There's one on the medial or big toe side of the knee, and there's one on the lateral or little toe side. And then we have ligaments. There's actually 4 major ligaments. There's one on the little toe side we call the lateral collateral, the medial collateral, the anterior cruciate, posterior cruciate. So those can tear. And that's important both from an acute injury, something just happened. It's also important when we talked about history. I've often seen patients, and I'll go, someone will be in their 50s, even 60s, and you talk to them and go, did you ever hurt your knee? You ever play a sport, or you had to take time off, or you were on crutches? Because for some of those patients, for many, the injury occurred at a time where we didn't have MRIs, and the patient was told to rest. They got better. They never could get back to their football like they used to. And it turns out they probably ruptured their anterior cruciate ligament, which was never treated, and they got through life pretty well, but as they got older, that cartilage started to wear out much sooner than it should have, and that's an important fact that we'll see when we look at the anatomy. So we want healthy cartilage, the white stuff on the bone, on both bones, femur and tibia, the meniscus, the cushion, and the ligaments. So Sherlock thinks about usual suspects. So who are the usual suspects in the knee? Meniscal tears, ligament tears, arthritis, loose body synovitis. How do these all connect to the anatomy we just looked at? That pad can tear. Now, I see 2 different types of situations where people have a meniscal tear. I see the younger set, the 20s, 30s, that were playing softball and slid into base and tore the meniscus. Those are usually going to go to arthroscopy, and we're going to either repair or trim out the torn portion. Then I see people in my age group, the baby boomers, and they have a tear, but many times there's no story. They didn't slide into base. They just got out of bed one morning, tried going down the stairs, and they felt something pop in their knee. These are degenerative tears, wear and tear, just like something can break on your car without you being in an accident. The meniscus can tear with an arthritic joint. And they have to be approached a little differently, but some of them will respond to arthroscopy. But the doctor needs to, through history, through physical examination, try and make an assessment as to whether he feels the meniscus is an important part of the pain generator. Ligament tears, either old or new, certainly can produce problems. A fellow this past winter was walking down his driveway and slipped and tore his medial collateral ligament, kept bothering him, but basically that healed. It went on and did well. Arthritis, one of the more common things I see day in and day out. And if you went to the library and asked for books on arthritis, you better bring a big wagon with you to carry them all. So I'm not going to try and pretend I can explain arthritis, but Let me break it into two simple areas. First is osteoarthritis, degenerative joint disease. That's the wear and tear type of arthritis. And by arthritis, I mean a wearing off of the cartilage. That's the type that most of us are going to get by the time we get into our 60s. Probably 40, 50% of people are going to have some arthritic changes in their knee. And because as you get a little older, you're not as likely to be playing racquetball, it may kind of creep up on you and you won't know it until you get an x-ray. The arthritis, osteoarthritis, degenerative joint disease, what are the factors that produce it? Well, one is genetics. I've been in practice long enough, I've had several generations of family members come through, and you do see sometimes trends where early arthritis occurring. So genetics plays a role, age plays a role. The older we get, the more likely we are to have some arthritis in our knee. Activity makes a difference. I've had a few ex-professional athletes I've seen through the years, and it just amazes me at a relatively young age how much damage has been done to their joints, hip and knee. And just as ordinary folks, and some people who really have hard jobs, standing a lot, walking, climbing, bending, lifting, repetitive activities that just wear a body down, and that cartilage starts to break down. Now, as a separate issue, loose bodies can occur, and inflammation, synovitis. If you were inside a giant knee and you felt the wall of that knee, you'd feel this slippery, smooth material called synovium. When it gets inflamed, we call it synovitis. And it used to be that we thought with osteoarthritis there wasn't much inflammation, but there's a lot of studies now showing these what are called cytokinases and different enzymes are elevated, even in osteoarthritis. So what's the other type of arthritis? Rheumatoid, psoriatic arthritis. Those are grouped into what's called inflammatory arthritis. I think you could put gout in that category. Where you get a lot of inflammation. Rheumatoid is basically an overgrowth of the synovium. That slippery material starts to overgrow. It damages the capsule, the ligaments. It erodes into the cartilage. As I said when I was talking about the hips, in my 30 years in orthopedics, I've seen the greatest advances in the treatment of rheumatoid arthritis through medications and injections. And it really has eliminated a lot of the major joint deformities we used to see. So the majority of cases we deal with now are osteoarthritis, for which there isn't any really disease-altering treatment that is going to slow the process that we can prove conclusively. We certainly have ways to treat the symptoms, and we hope that some of those techniques may help prolong the joint life. These loose bodies that come out in the joint are a result of that breakdown of the cartilage, and they get rounded off as you wear and tear them. So wear and tear, joint inflammation, cartilage loss, that's the kind of arthritis we're dealing with. Now, why does the knee hurt? And the reason I want to emphasize this point is if you understand what's causing the pain, then some of the treatments will make a little more sense. And in osteoarthritis, the wear and tear, I see inflammation and I see mechanical problems. If in the early stages you have, let's say 80% of the pain is coming from inflammation, 20% coming from some mechanical problems. If you take a strong anti-inflammatory, if you get a shot of cortisone, a strong anti-inflammatory medication, 80% of your problem will go away. And maybe you'll get a shot of cortisone excuse me, once or twice a year and you're doing pretty well. And then one day you'll come in and get a shot and it won't work this time. And your doctor will get an x-ray and he'll see that the mechanical portion is getting worse. The cartilage is wearing down, you're developing bone spurs, you've lost cartilage, you're developing cysts in the bone, and that can cause pain. It also causes thickening of this structure called the capsule. When you look at a joint, and this is the patella here, these reinforcements are the ligaments, and a healthy capsule is so important to a good functioning joint. And that's why one of the early things I'll do when patients come in with osteoarthritis and they can't straighten that joint out, one of the first things I want to do is send them to therapy and get that capsule stretched out. And I often tell them, you know, if we were going to play a game of basketball and I had a t-shirt on and you had a leather jacket I had soaked in salt water and put out in the sun and kind of baked it, and it was real stiff, I'm certainly got an advantage. And so you don't want to be in that leather jacket. And if you treat that and stretch that out and loosen that capsule up, you can get a lot of improvement just from that. I've always liked this little diagram, and what it shows is that arthritis is more than just the loss of cartilage. So on this side, we're looking at what we call normal. This side, we're looking at osteoarthritis. This yellow is supposed to represent the femur. These rounded areas are condyles. This little is the icing on the cake. That's the articular cartilage. Here's the cartilage on the tibia. This is the synovial cavity where the fluid can be produced. This is a normal synovium, sort of a thin structure, and that's that capsule we were talking about. But see what happens as arthritis progresses? That capsule gets thicker. That synovium overgrows. The cartilage becomes pitted, little potholes form. Those fragments come off, get embedded in the synovium, cause more inflammation. As the protection of the cartilage goes away, the bone is exposed to higher stresses, and you get little microfractures. The bone here is what we call trabecular. It looks like a sponge, and those little spicules of bone can fracture. And studies have been done that show that that is what happens. And as those heal, that area becomes stiff. So you get into this sort of downhill slide where these things kind of play on each other, and as the bone gets harder and then the cartilage gets more pressure on it, and it tends to wear out, and more debris comes out, the capsule gets thicker and the synovium gets thicker. So that's the cycle, that's the process we're dealing with. So many times we're not just dealing with one thing, one pill, one shot, one brace. It's a combination of things. And you look at the structures and you go, well, why do those mechanical problems produce pain? The interesting fact is the articular cartilage has no pain fibers. You can stick a needle in the articular cartilage, that's that coating on the bone. Wouldn't hurt. The synovium has some pain fibers, but it has these baro or pressure sensors. And that's when you look at the weather maps, you see the highs and the lows. When you see the lows, that's the time when your joint's going to hurt you more and you'll be able to predict the weather. Ligaments, they're involved a lot in position sense. They can produce pain, but they're more involved in knowing where your knee is at and telling your brain which muscle to pull on. The bone has lots of pain fibers. We know, any of us that ever had a fracture can tell you that for sure. There's this newer thing we're realizing that we see on MRIs called bone marrow edema or bone marrow lesions. And again, not to bore you with all the details, but we get an MRI, it's like an old-fashioned black and white TV set, and if we see these bright signals coming out of these areas where there's a lot of pressure, we know that some of that is coming about from the overload of that bone, and that's producing pain. So, because we know that it's not all inside the joint, if you inject a numbing medicine like lidocaine into a painful knee, it only relieves about 60% of the pain. So we know that there's some other parts are hurting, and that part is the bone. So that's a significant thing. Just to introduce a little treatment here, this is a thing called subchondroplasty or calcium phosphate. And what it is, if we're thinking that these dark areas are signs of microfracture by grafting it with this material, and this is done at surgery under anesthesia after you've had a knee scoped, that seems to help some patients. Newer procedure, and we'll learn more as time goes on. So it's a mixed bag. You know, it's easy to jump to conclusions. I've had a lot of patients seen through the years where someone walked in a room, told them they had arthritis, and said something about a total knee, and kind of left them sitting there. Well, everything's not arthritis in the knee. You can have no arthritis and your knee can hurt. So that's always a challenge. I saw several patients today in that situation. Took their x-rays, looked good, but they're having painful knees. Now, it may be because the x-ray doesn't show it as well as the MRI. But we also know there's patients who have some arthritis, doesn't bother them. All the time I'll get x-rays of both knees, and both knees will look just about as bad, but one knee won't hurt and the other will. And of course you can have pain and arthritis, but doesn't mean the pain's coming from the arthritis. So you can see there's a mix. And of course, one of the common things, you have arthritis and you have arthritic pain. What I'm trying to do here is just kind of tell you, we need to be, like Shakespeare said, there are more things in heaven and earth than are dreamt of in your philosophy, and that's for us doctors to realize that we can't just look at one x-ray and jump to a conclusion. Or my grandmother had a nice way of saying it, there's more than one way to skin a cat. And I try and keep that in mind. And these are the 5 fingers methodology, and that's just a simple way of saying, when I see a patient and I've got a diagnosis of arthritis, I try and think of these 5 categories of treatment that might help that person. There's therapy, physical therapy, there's medications, injections, bracing, surgery. So I think it's worthwhile exploring all of them. I think a fundamental, I don't care what your knee's like, if you've got some arthritis, you need to visit with a therapist. Strengthening the joint, the muscle control. Numerous studies have shown that can diminish pain. It kind of goes against your common sense. You think, you want me to exercise my arthritic joint? And the answer is yes, but you need proper instruction how to do it, and a physical therapist is the person. We follow a program here called the Shelbourne program from a well-known knee surgeon down in Indianapolis, and he designed it, and it's worked out quite well, in which we work to get the range of motion back, work to get the strength back, and that will often diminish the pain. One thing I always keep in mind, a stiff knee is a painful knee. I see so many patients with painful knees, and you look at them, you watch them walk, and you'll see they're not straightening their leg out when they walk. They're walking around on a flex knee. And if you want to see what that's like, just try it sometime. Walk around with your knees bent and see how long you want to do that. It's tiring, it's painful, and it overloads the joint. So we have a knee arthritis school. We teach patients self-management techniques. Just like if you're diabetic, they'd send you to see the dietitian and get some advice on how to eat, exercise, and use your medications. Same in arthritis. I think this is often overlooked. And even for the person who's going to go on and have a knee replacement, they're going to do better if they've kept that capsule supple, and not let it turn into that stiff leather jacket I talked about. They're going to have a much better recovery. And they're probably going to go much longer without needing to have surgery. So getting in to see a therapist, and I've had patients say, well, I'll just go to the gym and work it out, and they get on the leg press machine, they come back with their knee all swollen. So it's not a do-it-yourself program. You want to get the motion. First, you want to get the leg straight so you don't walk around the bent knee. You need flexion. You need the bending. To get in and out of chairs, in and out of a car, you need to do that. And then finally, when we get the range of motion, then we work on strength. And the therapists are really good. Nowadays in medicine, it's gotten to a point where we need to see patients more quickly, and unfortunately we can't spend as much time as we'd like to. But therapy does spend more time because they'll see you more frequently, and they'll look at everything. They are excellent diagnostic work. You want to look at the joint above and the joint below. You want to look at the hip. Are there problems there? I've seen patients who were just about ready to have a knee replacement. They came in and got an x-ray of their hip, and they had a hip arthritis. That was their problem more than their knee. I have patients who walk on the side of their foot, like this fellow down here you see, and he needs to get that straightened out because he's putting abnormal forces on his knee, and a device like this can help, orthotics. There are some folks with braces that we can help them with. The therapist will often tape the leg and come over and tell me that, that looks like this patient would be a good candidate for bracing. So physical therapy, that's the foundation. Medications. There are lots of different pills called NSAIDs, non-steroidal anti-inflammatory drugs. Here's one I use myself called Celebrex. I know people get all panicked about this a few years ago, but it's stood the test of time. But you can get Motrin, Advil, Aleve, Naprosyn, Indocin, Relafin. It goes on and on. Some prescription, some non-prescription. One interesting thing to be aware of is that 7,000 to 8,000 people are reported to die every year from taking anti-inflammatories. Well, that sounds terrible and scary, but millions of people take these pills, so I don't want to scare you, I want to inform you. If you've got kidney problems, if you're diabetic, if you've had liver problems, if you've had a history of ulcers, you need to check with your doctor. Even if you don't have any of those things and you're taking this on a daily basis, month after month, you need to get checked to make sure it's not affecting your kidney, not affecting your liver. So there's some other issues. There are some gels that are coming out now that you can rub on the joint, and you get the medicine in that way without taking it in through your intestines, and it focuses the treatment and you get less side effects, systemic. Here's a different, you hear about chondroitin sulfate glucosamine, and if you go to the drugstore and you ask for these, here's the names down here, glucosamine, chondroitin sulfate, you'll see row after row of these boxes, predicting all sorts of wondrous things they're going to do. And it's been studied. I try and do it like the FDA does. They look at the safety of something and the effectiveness. Obviously, if something's dangerous, you really better be effective. If something is kind of plus minus on the effectiveness, but it has hardly any risk, then it's worth consideration. I feel that way about the cosamine DS, which is a chondroitin sulfate product. Tried it myself. I suggest you take it with applesauce instead of water because it's hard to swallow. It's a pretty big pill. And you need to take it for about 3 months to see whether it works or not. And I'm not connected to the company, but it's just something to make you aware of a possible approach. Some patients really can't take the anti-inflammatories. Injections. 3 types: cortisone, viscosupplementation, and platelet-rich plasma. Cortisone is an anti-inflammatory. I see so many patients, I think they're going to run out of the room when I talk to them about a cortisone injection. They've heard all these terrible things. It dissolves your bone, your cartilage. And the truth is, it's like anything else. Offer you a glass of water, I don't think you'd say, oh, God, I could drown. You'll just say, well, I guess I'll give it a try. And it is very effective, and for a lot of my patients with arthritis who aren't ready to go on to surgery, it can make life a lot more comfortable, and they can do pretty well for many years. Like anything else in life, you want to use some judgment. If a 20-year-old wants to play beach volleyball every Friday night, it's not a good idea to inject them every Friday night so they can play a sport. But if it's a 50-year-old man who has to go to work, then getting 2 or 3 or 4 shots a year is not such a bad way. Viscosupplementation. These are the gels that you'll hear about. You'll hear the names Synvis, Supartz, Orthovisc. Basically, it's hyaluronic acid. It's a chemical that was found to be low in the joint fluid of people with arthritis. I've been doing this for 15 years. I've tried all the different brands, and I think it is very helpful for a lot of patients, but you never know which one it will be helpful for. If you ask me what are my success rates, I would say about 6 out of 10 people that we give these to find it worthwhile. And so it's 1 shot a week for anywhere from 3 weeks to 5 weeks, depending on which brand you're using. It doesn't float the joints apart. It doesn't open up the joint. It basically lubricates the joint. I mentioned this just because patients sometimes ask about it, platelet-rich plasma. Basically what it is, within your blood, you've got red blood cells, white blood cells, and you've got platelets, which are involved in blood clotting. So when you cut yourself, platelets go there and kind of plug the hole, but they also release some chemicals that call other cells in to repair the injury. So the idea was if we could concentrate these platelets and inject them into an arthritic joint, that maybe it would help heal. Medicare doesn't pay for it. I don't know of any insurance company that pays for it. It's fairly expensive because we take a blood sample and then we have a centrifuge brought in that we spin it around, separate out the platelets, and then inject it into the joint. I've used it some. I think the jury is still out on this. It's cost about $500, and some of my patients have had it and felt it helped them, and others felt it was not of any benefit. So I'll just impress you with all these chemicals here, but these are some of the enzymes and growth factors that are released. There's a lot of literature on it, and someone once said it's sort of like caffeine is, in coffee. It kind of gives a little jolt to the joint and helps it. So who knows? But it's some. I haven't seen any harm from it because it's your own blood products, and I have seen some benefit. It just happens to be expensive. Bracing, you can start at the Jewel. You can go to a sport goods store and get some elastic supports, or you can go all the way to these custom-made unloading braces that you see over here. They can cost over $1,000. Sometimes covered by insurance, but a lot of times not. Very helpful for some people. Usually a person with a longer leg, a better contoured leg, they'll do better. Surgery. Well, what do we treat in a knee through a scope? Well, if a person has a torn meniscus, we do meniscectomies. If they have an overgrowth of the synovium, that lining, we can clean that out. Debridement, those loose particles of cartilage that break off, we can get those out. We've got some techniques. You hear a lot about stem cells, and best stem cells are your own, and we do a thing called microfracture when it's appropriate and actually drill into the bone, and that releases those stem cells. There's also a procedure called ACI. It's cartilage implantation. I went to Sweden in '96, '97 to learn how to do this, and again, there's very limited usefulness for it. It's basically for younger people who have loss of a small portion of their cartilage. Mosaic plasty, it's sort of like the hair transplant for us men, where you take healthy cartilage from one part of the knee and try and transplant it into another part. All these have worked to some degree. The thing I just tell patients, though, if you're thinking about microfracture, ACI, or mosaic plasty, trying to restore cartilage in a limited area, you have to realize there's an upside and there's a downside. The downside is it could accelerate things, where you'd go from a situation where you were having problems but you could tolerate it, to a problem that you just can't tolerate, and now you're going to have a knee replacement. So you've stepped up to the more expensive table. Subchondroplasty, we talked about that before. That's that little microfracture, those lesions, those bright spots that show up that we think are due to bone overload, and by grafting those, like a stress fracture, seems to help. Osteotomies, what is that? Well, put it in simple terms, I guess you can call it breaking the leg and realigning it. It's done surgically. Late 70s, early 80s, I did a lot of these. A lot of other doctors did a lot of them. Knee replacements in those days were not as reliable as they are today, and it was thought in younger patients that was an appropriate way to go. I certainly don't do these. It's been a long time since I did an osteotomy. I don't see other doctors doing many of them. And I think as the joint replacements got better, this wasn't as desirable an alternative. Joint replacement, a few things we'll talk about with that. Just arthroscopy, cleaning out the joint. What do we do? You see this piece of tire that's worn off a truck tire? When we look in a joint, sometimes we will see these little white particles. I don't know if I got a picture here. Here it is, that I took out of a joint, washed out. And you can see here's the crater where it came out of. So we can clean those up. We use these suction type devices. We can remove some of the synovium or the lining in the joint. We can trim up the meniscus. And there's been lots of studies done. I mean, you look at the follow-up 2 to 4 years for some patients with arthritis having these things done. Probably about 3 out of 4, 2 out of 3 did maintain their improvement for a number of years. And we see some 10-year long studies treated. 2/3 of them didn't go on and have a knee replacement. So it does seem to help some patients prolong the usefulness of that joint. Cleaning out these joint mice can help. Sometimes grafting the area, this microfracture, we make these little holes in the bone to grow cartilage. ACI, the autologous chondrosat implantation, this thing I did in Sweden. And then we get into the mosaic plasty, where we take these plugs of bone and cartilage and move them around. Unicondylar partial knee replacement. What's that mean? The human knee has 3 compartments: medial, big toe; lateral, outside or little toe; patellofemoral is your kneecap. Now we can replace each of these compartments without doing the others. And what we see is osteoarthritis, to a large part, is a segmental disease. When you look at progression here, this all-back system we use, you can see here just maybe some mild narrowing. I saw 2 people changes like that today. These 2 and 3 levels are candidates for a partial knee replacement, where we just do this portion of the joint. If I had to have a joint replacement, and there was any way I thought I was a candidate for a uni or partial, that's what I would have. And the patients do much better. But obviously, if you have the more advanced stages of arthritis and you have a partial knee replacement, that's a mistake. So you have to select patients carefully. It addresses the ligament imbalance. It straightens the knee out a little bit to some degree. Takes care of the sclerotic bone pain that people have, the area we're talking about, to get the little microfracture, the bone gets hard. Preserves the knee. If you're 50 years old, it's certainly, you got to think about that option if it's available. If you've got involvement of all 3 parts of the knee, it's not going to work for you. But we see there's a large segment of people that only have this little Venn diagram, if you all are good at reading Venn diagrams. But basically the message here is that this segment of people just have unicompartmental. 166 out of this whole group would be candidates. So some doctors don't do the partial. They just say, I think the total's better. But for me, I think it's something you need to educate yourself about. Here's what it looks like. Basically, we just resurface that part. The rest of the knee is okay. It's a complex discussion, and when the doctors start arguing over it, and there's pros and cons. But certainly you see people with over 20 years in the high 80s to low 90s survival. It means the thing's still working. Even one study showed that the uni actually better results, 90% hardware survival versus 76. But the thing for me is survival is, I think most of us would agree that a well-done unicompartmental will always beat a well-done total knee. So now we'll just kind of sum up here and get to the last category, total knee replacement. And we're going to continue. We've got our website, boneandjointworld.com. If you get the address, you can go visit, and we keep adding to it. We've got podcasts. You can listen on the radio, in your car. If you get the Bluetooth, you can listen on your computer. But I want to explain more of these things. Today's kind of a flyover to kind of show you the different categories, but three major types of joint replacement. We talk about total knee. One is cruciate retaining, which is what I do the most of. With those 4 ligaments, you maintain 3 of them. Posterior stabilized, you maintain 2 of them, and constrained is for the person who's down to maybe 1 good functioning ligament. So my view is this. I've had patients come in and said someone told them to, avoid knee replacement until they're crawling around. I don't necessarily think that's a great idea. One, it's not a good way to enjoy life, and 2, it just causes increasing damage. When it becomes obvious the joint's worn out, to just it'd be like driving your car. If you had a flat tire, you just keep driving. You're gonna destroy the tire. You're gonna destroy the wheel. It's just not a good thing. And so when you start getting all that deformity, it just makes it more difficult to do the joint, and you may go from what I consider a better approach, the cruciate retaining, to now you have to have posterior stabilized, and in some cases all the way to a more constrained device. Computer-assisted surgery, this is what I use. Ingalls purchased this for us a while back, and I've been using it for many years. It's a means of putting in the total joint, really getting the alignment just right, and it allows us to avoid using these intermedullary rods we used to put up the femur. You hear a lot of discussions about where to go and how to get it done. You want to go someplace where they do a lot of them. A lot of studies have shown that both surgeons and hospitals that do more joints are going to do better. Ingalls really has a focus on joint replacements. Worked there a number of years. Excellent hospital, great nursing staff, very good, very low infection rate. So here's the rooms are all separate rooms. We have a orthopedic wing that all our patients stay on, and all the nurses are very experienced in dealing with patients. So what's my message here for those of us as old as me who remember Ward Bond? He used to be the wagon master. He was the guy who told you how to get out west. But obviously if you didn't want to go out west, it wasn't worth taking all the risks. So when you have a knee problem, you want to try and fit it to yourself. You got to know yourself in a sense. I mean, if you're a person and you love reading and sitting around and watching the grandkids play out in the backyard and you're happy, that's maybe you just get your knee scoped, or a shot of cortisone may be all you need. If you're someone who wants to play some doubles tennis or wants to travel and get around more comfortably, you may be at a point where knee replacement's the right thing for you. And certainly it's not a one solution for everybody. Well, I hope we answered some of your questions. Again, remember boneandjointworld.com. We're going to keep adding to it. And if you have any questions tonight, we'll try and answer them. And if you don't, and some come to mind, and you can just type them in later, and we'll try and get back to you. So I hope that was helpful.
Thanks, Dr. Smith. Okay, looks like we got just one question come in so far. First is, let's see, is there a weight requirement for knee replacement surgery?
Well, that's a good question, and that's something that's discussed all the time. Put it this way, there's a study that looked at the weights of patients and complications. And there's a number, instead of just using weight, there's a thing called BMI, which, like all measurements, is not perfect, but it includes your weight and your height. And there are some studies that have indicated that when your BMI is over 40, your risk of getting an infection is several times higher. If the BMI goes up to 50, the chance of infection is like 10 times or more higher. Combine that with perhaps being diabetic, it really is great if you can lose weight. However, we have to be realistic. I certainly know as I got older, it's not easy to lose weight, and it's sure easy to gain it and a lot more fun. But it is a fact, and and these are things you have to discuss with your doctor and decide what risk. And if you think you can get your weight down, you're better off. And that BMI number, 40 is a landmark. It is not an absolute, but it is something to at least think about, because once you get over that, the infection rate does get higher. So I wouldn't say that there's an absolute weight limit, and I try and consider everything. I see some patients that have both knees so arthritic they just can't exercise. If they're willing to accept the increased risk, then we go ahead, because for some of them there's no other hope of getting relief.
Okay. So far we have no other questions, so I'd like to thank everyone for attending. As Dr. Smith mentioned, we are online at boneandjointworld.com. If you do think of questions after the webinar is over, if you go there, there's a contact us page. Just put in your name and ask your question. We will get back to you, most likely via email. We do these webinars about once a month. I know there's one already scheduled for next month. And it seems the whole world is on Facebook, so now we are too. You can find us at facebook.com/boneandjointworld. Thank you, everyone.